So at this time, I think we can have some discussion, and therefore I would like to invite all the speakers to come here, to join us, to answer the many questions that will come, certainly. So please come here. We have chairs for all of you.
Almost all.
I kindly ask person who wish to make question to indicate the speaker the question is addressed to.
Dr. Ahmed Abdullah from Egypt, pediatric gastroenterologist. Actually, my question, we know that functional abdominal disorders are functional. And so we have to define that any patient with IBS that have inorganic lesions, if it's exposed to an antigen outside, should be excluded from being a functional abdominal disorder. And I prefer to have it again, to put him in the non-celiac gluten sensitivity disorders. Otherwise, the functional disorders will not be more than function. Why it is function? And responding to an antigen or any external factor. This is my question.
Only to answer your question, I think that the dietary factors can have an important role in eliciting these functional symptoms in gastrointestinal functional disorders. And I think that non-celiac gluten sensitivity can be included in the wide spectrum of IBS-like syndromes. So I think that there is an evident overlap between non-celiac gluten sensitivity and IBS symptoms. Maybe the most striking difference, in my opinion, is the presence of extraintestinal symptoms in the subgroup of patients who have a true non-celiac gluten sensitivity.
Thank you.
Luca, want to comment?
Yes. Just a comment, yes. I agree with Umberto and with you that we need to share IBS or IBS-like syndrome and non-celiac gluten sensitivity, and probably a double-blind challenge could be helpful to do so, to divide IBS from non-celiac gluten sensitive patients.
Thank you.
Next.
Giacomo Caio, Bologna, Italy. Two short questions. The first is how is intestinal permeability in non-celiac gluten sensitivity, since there are controversial data in literature. First data says that there wasn't an increased permeability, and now the latest data says that there is an increased permeability. And the second question is, are we sure that a patient who fulfill the ROM3 criteria for IBS, who respond to a gluten-free diet, could be called non-celiac gluten-sensitive patient if this patient doesn't has neurological manifestation, skin, extraintestinal symptoms. Thank you.
Who wish to answer the intestinal permeability question? Alessio.
I answer the first one because that's only an apparent dichotomy, actually. The first study, they showed there is actually more tight junctions, so less gut permeability that we published. It was a study was done on non-celiac gluten-sensitive patients on a strict gluten-free diet. We just published 2 months ago on similar patients that if you take their biopsies and you put in a special device and you expose to gluten, there is a drop in increase in gut permeability responded to gluten. So the apparent dichotomy was due to the fact that contrary to celiac, that no matter in which diet they are, they still have an impaired barrier function. even when they're gluten-free, for reasons that we only partially understand. People with non-celiac gluten sensitivity on a gluten-free diet, they have a compensatory, tightness of the junction in between cells, and therefore much less permeability. But when exposed to gluten, like celiacs, they have an increased permeability, just the same. One more difference, I'm sorry, is that when again, this paper that I was mentioning was published a couple months ago in Nutrients, show that when you do this with biopsy from celiac patients, this drop with this increase in permeability is sustained over time. For people with non-celiac gluten sensitivity, this drop is just temporary and then eventually recover.
Who wants to answer the second question? As far as me, I think that patients with IBS responding to a gluten-free diet can be named as gluten sensitivity patients. We say that gluten sensitivity is a very chameleontic disease which can present with either IBS or neurological or both symptoms, but the major issue is response to the gluten-free treatment. Of course, you have to standardize the challenge, as we said, do it with gluten and not with FODMAPs, because otherwise you can go into confusion. But if you standardize the challenge, you can reach a diagnosis of gluten sensitivity even in IBS patients. Other questions? Yeah.
Can I ask, how do you distinguish between patients with non-celiac gluten sensitivity who have the correct HLA type, IDQ2 or DQ8, from the group of patients who have potential celiac disease?
Question. Who wants to answer?
Can I try to answer?
Why not?
Can I try to answer? I think it's very difficult to distinguish these two subtypes of patients. I tried to show you the data about intestinal deposits of tissue transglutaminase of IgA class, but it's too early to consider these deposits as markers of early celiac disease, in my opinion. We are studying our patients with suspected non-celiac gluten sensitivity with these deposits, and preliminary data are showing that about 10-20% of these patients are positive for these deposits. This can be an option to identify this patient. Another option is to study endomysial antibodies in the organ culture medium, but also this test is controversial in the scientific opinion and literature. There are some data in favor of this test, other data that are not demonstrating its value, so it's difficult.
Alessio, please.
I want to just add one more thing, Marius, that also is matter of definition. Currently, if memory serves me well, that potential celiac are individuals with positive serology, autoimmune serology, that by definition rule out non-celiac gluten sensitivity. So if we want to stick with the current definition of a potential celiac disease being a situation which you have positive anti-TTG antibodies by default, that individual cannot have non-celiac gluten sensitivity.
Quick.
Say it again?
Quick, very quick.
Well, the anti-Gladden antibodies is a totally different story. Of course, if you are positive for, and again, this is a very biased opinion. For me, an individual that has positive anti-Gladden antibodies means only three things. This individual is eating gluten by definition. Somehow gluten comes through the intestinal barrier. And three, the immune system does its job, and also antigen mounted immune response. You can have a rotavirus infection or other kind of a parasite infection that you have positive anti-Gladden antibodies for that reason. So that just simply say that there has been an exposure to these peptides, that's all. Said that, it's still, of course, theoretically, if you are HLA compatible, and you have symptoms, and you have positive anti-Gladden antibodies, so in other words, criteria now fulfill the diagnosis in non-celiac gluten sensitivity, can you be celiac as well? Maybe in the future. But by the definition now, if you don't have the TTG antibodies and you have the histology that is negative, because that's another criteria, that cannot be. So at that moment, those symptoms cannot be due to celiac disease, at least with the current, criteria. If we want to add as a criteria the TTG deposit that Umberto was mentioned, then we have to revisit the entire discussion. But I don't know if we're there yet.
Coming back only, short comment for potential celiac disease. I agree with Alessio that the present definition of potential celiac disease implies a positivity for serological tests, but we don't know if potential celiac disease is only this aspect or something more. So in the future we can have other data.
Yes.
Another question, please.
Yes. In connection to the extraintestinal manifestation of celiac disease, during our work in Egypt with pediatric with celiac disease, sometimes we have biopsy from every part, from the duodenum, stomach, and esophagus. And sometimes we have esophagus with a lot of eosinophils, a very lot of eosinophils. So how can we explain, is this as an association or a reflection of the disease, eosinophils in the esophagus?
Who wishes to answer? No, please do that.
I don't want to monopolize the discussion here, but I'm not even sure that I understand correctly the question. But again, I'd risk to be a broken record here. We have strict definition that, of course, may be revisited at any time. But if you do an endoscopy and you do the random biopsies and you find, the damage on the intestine that's characterized celiac disease, and you don't have any GI symptoms, if that was the question, so you can have extraintestinal symptoms. By definition, that's an individual that fulfilled the criteria. You don't have to have, necessary GI symptoms. Remember that intestine is 7 meters long, and if you have, a few centimeters damaged, that they do something unique, like bringing iron in, you can have anemia and nothing else. So that's not surprising. I'm not sure that I answer your question, though.
Because definitely the therapy will be different. If we can only give this patient gluten-free diet or add to him the specific treatment for eosinophilic esophagitis. So it is very important to correlate. If this is correlated, so gluten-free is sufficient. If not, I have to give gluten-free in addition to the specific treatment of EO.
Well, of course, part of the criteria that the symptoms needs to go away once you embrace a gluten-free diet, and the autoantibodies, they go back to normal.
Yes.
Okay, another question?
I'm Ritu Verma from GI in Children's Hospital in Philadelphia. Alessio's question for you. I know you don't want to monopolize. Fascinating study with schizophrenia. So I don't know if you can answer this question or not, or if you have the answers at all, or you cannot discuss in this forum. But do you see an actual reversal of schizophrenia or autism? And I guess we'll leave autism for a second, but just as schizophrenia on a gluten-free diet, do you have data to show that there's actual reversal of the symptoms?
So again, I'm not an expert in the field, so I have to rely on my colleagues, psychiatrists, they're experts in schizophrenia. This is an N equals 7. This is as many folks as been so far in the go-to. It's a blind. It's double blind, but because it's individual schizophrenic, it really doesn't matter. They have specific scales to measure the severity of schizophrenia. All these 7 individuals not only improved on the scales, but the first time ever, they were able to be taken off medications. The caveat, though, is temporarily, because as soon as these individuals leave the facility, they will not stick with the program. Now, for autism, it's much more complicated a matter, as you can imagine. Also because the discussion of the gluten-free diet, yes or no, within both the scientific and the parents' community is a very heated debate, and that I believe has been poisoned by extreme positions. The believers pretended that all the kids with autism should go on a gluten-free diet because that's going to work. The non-believers said there is no evidence whatsoever, because if you look at the prevalence of celiac disease in kids with autism, it's only 2%, therefore there is no business to go on a gluten-free diet. In my humble opinion, they are both wrong. Again, these are complex diseases. They can reach the final destination by different means, including possibly food intolerances or sensitivities like non-celiac gluten sensitivity. The caveat and the challenge, again, particularly for groups like schizophrenic and autistic kids, is to find a biomarker to target this population that most likely will respond to gluten-free diet. For schizophrenia, we found this biomarker in being TTG6. For autism, we don't have that yet, other than the anti-Gladden antibodies with all the limitations.
Can I ask a question? Is it actually a true epidemic of schizophrenia, or is it just a shift of diagnosis that
I don't know. I mean, again, both schizophrenia and autism have been suffering by not clear definition till the recent past. So most likely, this is a combination that now having better definition, people are better diagnosed, but there are people that believe that, again, there is clear an epidemic of schizophrenia. The ones for autism is out of discussion, and it's a scary epidemic. You know, you have seen the tip of the curve. I've never seen anything like that before.
So if we were to follow up with that, does that mean that if there are other complications that happen from celiac disease, that it's possible to say that maybe those would be reversible? I mean, so far the teaching has been, if you have some complication, it's done, it's not reversible. The gut is reversible, maybe not others. So can one take it further, or there's more work that needs to be done?
I have no idea. The only thing that I can tell you that, for example, in our clinical practice, I'm assuming this is shared with the others, if you have peripheral neuropathy, that can be reversed if the diagnosis has been made on time. So I'm assuming that there is a level point of return the neuroinflammation can resolve. But if you go after that level, so that you got, you know, a permanent damage of whatever structure or center or cells that are responsible for, you know, these symptoms, that there is no way that you can come back.
Thank you.
Please.
I'm Mohammad Rostami from Iran. We had 3 different presentations regarding the duration of non-celiac gluten sensitivity. As Carlo said, for the duration is something around 6 weeks for the first phase. But 2 other presentations said the different duration for gluten-free diet, especially for IBS patients. I would like to ask, what's your suggestion, finally, for IBS patient, the duration of gluten-free diet and then gluten challenge? Thank you.
We didn't discuss this specific issue, but I think that I mean, the 6 weeks period of time for the gluten-free diet is the minimum period that we need to assess the response, and I think it could be longer. But the critical issue is that the response is usually seen quite quickly. I was very intrigued by the data shown by Mikkel, with people responding after 2 months, but you know, it's much more difficult to establish a clear-cut relationship between gluten and IBS in those cases, I think. Please, Mike.
So IBS is a mixed bag. That's, I think, a vocabulary I learned from Alessio. And probably gluten sensitivity is a mixed bag in between that mixed bag. We know that some people believe it's mainly FODMAPs, and other people believe it's mainly ATIs, and it might be even a third substance. And maybe all of those people are right at the same time. And if it's different substances that will induce this reaction in terms of FODMAPs, it might not be an immune reaction at all. It might be just what we know from lactose intolerance as well. It might be pretty fast. And in terms of ATIs, it might take some longer time. So it might not be that surprise that patients in our group reacted in very different time spans. Some were really fast and others were really slow. So it might just reflect the heterogeneity of the disorder and the heterogeneity of the actual stimulus.
Hello. This is for Alessio Fasano and Umberto Volta. A couple of years ago, I listened to a gluten summit that you participated on, and there was also this presenter, his name was Aristo Boshdani, that he participated on the gluten summit. And he and other presenters state that there are many molecules that the body can react to when it is reacting against gluten, not only the alpha-gliadin, but many others. They state that are around 60 molecules, and that there's a hole in the diagnosis, especially for non-celiac gluten sensitivity, because the only molecule that it's being measured against gluten is the alpha-gliadin and not all the other ones. And they also show a laboratory who is doing its work, measuring around 10 of those 60. So I just wanted to know how accurate is that, if the body is reacting to, or could be reacting against 60 different molecules, and could that be diagnosed as a non-celiac gluten sensitivity? And the last one would be, what's the prevalence of non-celiac gluten sensitivity as right now? Thank you very much.
I can answer for the prevalence. We don't know the real prevalence of non-celiac gluten sensitivity. There are different data in literature. In primary care in USA, we have from 0.6% to in tertiary care we have about 6%. In our Italian multi-center study, we identified over 12,000 subjects with non-celiac gluten sensitivity, a prevalence of 3.2%. But you must consider that these patients were patients addressed to centers specialized for the diagnosis of gluten-related disorders. As for the other question, I know that there are probably many reactions to gluten, not only alpha-gliadin, both in celiac disease and in non-celiac gluten sensitivity. And in non-celiac gluten sensitivity, probably we know that other proteins not included in gluten, such as amylase trypsin inhibitors, can have a role. But amylase trypsin inhibitors probably can have a role also in celiac disease because they are activators of innate immunity. So we have many things to discover again in this issue.
Okay. The last question, please.
Elżbieta Jarocka, I'm from Poland. And could you tell me how we can exclude wheat allergy? Because it's very hard in practice. Because AGE dependent is quite easy. You can do tests and you have AGE antibodies. But in fact, without food challenge, you cannot exclude non-AGE dependent with allergy. And this is positive. In children, I don't know what I should diagnose, non-celiac, gluten sensitivity, or non-AGE with allergy in cases.
Who is answering?
I can try to answer. For example, in our trial, we exclude wheat allergy by means of IgE, immunoglobulin, and skin prick test. Otherwise, but in the case, the best choice also for allergy is the blind challenge. So you can discover during the blind challenge if the patient have an allergy, for example, or an allergic reaction. So otherwise, you can always, the challenge is the final answer probably. Also in the case of non-IgE allergic
It's exactly
disorder.
the same. The definition of non-AGE
Yes,
dependent allergy and non-celiac gluten sensitivity is exactly the same.
Yes, it's close the same.
Free diet, then improvement and positive oral challenge. So I'm really confused when I have to put diagnosis in children. This or this.
So if I can add, I'm so sorry to really get involved again. That's exactly the point. There is no way currently in terms of clinical setting to distinguish if you have a non-IgE mediated food allergy, including, wheat allergy. And we've been really asking the question, are we really facing individuals that have another entity, or are we just simply facing people with wheat allergy that are non-IgE mediated? Again, we are almost finished the studies, and there are some pathways and genes that are totally, skewed Th2 response that is typical allergic. And I can tell you that there is a subgroup of what we currently define non-celiac gluten sensitivity individuals that actually they have non-IgE mediated wheat allergy. There is. It's small. In our experience, it's 10–15%, but it's there. It's definitely there.
Okay, I think time is over. It's time to close this very interesting meeting. Let me remind you that we had very interesting talk about the new standards for diagnosis of non-celiac gluten sensitivity. We heard about news on the serological biomarkers of non-celiac gluten sensitivity. None is entirely specific, but together the picture seems to be a little bit more clear today than in the past. Then we heard about the important relationship between non-celiac gluten sensitivity and IBS, two different studies, but with similar proportion of patients responding to the treatment with the gluten-free diet, and eventually the very interesting and fascinating overview of the relationship between gluten and neuropsychiatric disorders. I think we can agree with Professor Volta that the road for non-celiac gluten sensitivity is a long and winding road, but in the famous song from Paul McCartney, there was a door at the end of the winding road, and we hope to see the door quite soon. So thank you to the speakers, thank to all of you. Now I think it's time to having the reception. Don't know if it's gluten-free or high in gluten, but let's see. Thank you very much.